Well, I want to thank all of the panelists. That really great examples of programs that are working and innovative approaches that you've tried. I have a couple of questions, and then we'll open it up to the audience for questions if you'll just line up at the mics. But first, Sarah, I want to ask you a question about the capable model and how as you expand to 21 sites, how are you funded? What are your different funding streams?
So it's been lots of different ways. Some foundations, so it's within the Michigan Medicaid waiver system now, and they've had great results. The Weinberg Foundation's been involved in spreading it. The VA is piloting it in Boston. It's really been a couple of ACOs are testing capable. We're hoping to be working with a PACE in Massachusetts soon. So it's been a nice mix, and we've been enjoying watching that to see how it works for different kinds of payers.
Thank you. Oh, go ahead.
Will, can you tell us? I love the concept of that house, that building that was built for the homeless, end of life for the homeless, and then also the being able to provide clinical care. Who paid for that?
That's the part we don't talk about, right? No, it was paid for through all of the health systems in Portland, so they all contributed. Care Oregon, so the big Medicaid and special needs Medicare health plan where I work, contributed. Central City Concern, which is the city's large housing and healthcare organization for the homeless, contributed, but they also went to market with tax credits and other issues that have to do with real estate that I only know as much as I just said. But it's a number of funding streams that have gone into it.
And if I can add to that, the group of funders, it's a collaborative funding model, and we're still meeting to continue. What are the type of services that need to be provided and included, and there's additional funding needs that are coming forward, but it is a really community-wide collaborative effort.
Yes, I'm impressed. Yeah, absolutely.
And then you did not get to cover the PACE case study and model, and I wondered if we could pull back up that slide from your presentation.
The slide with the heart in the middle. So, and first of all, to qualify for PACE, there are criteria. You have to meet a level of care door. So you have to be eligible to be in a nursing home. You have to be at least 55 years or older. You have to live in the geographic area of that particular PACE site. You have to be safe in the community with the sort of PACE. And of course, if you have Medicaid, then you don't have to pay that copay part. In most PACE sites, the majority of the people are dual eligible with Medicare and Medicaid. And once you enroll into PACE, PACE literally becomes responsible for all of your care. So we're capitated and we're at risk. We get X number of dollars each month, and with those dollars, we provide all of the services: home care, transportation, meals, clinical care, if you have to go into the hospital, if you need skilled care, whatever the services are. So about 2 years ago, we had this woman come in. She was 62 years old, and she came in to be assessed to come into our program. And actually, the first time that she came, she was so ill, we ended up sending her by ambulance to the hospital. After she got out of the hospital, they brought her back to be reassessed, and she was, again, 62-year-old with stage 4 metastatic non-cell lung cancer. And for those of you who don't know, there is no cure. This is one of those, there's no cure, and there had never been a conversation with her about the fact that there was no cure, and they continued to offer her treatment. So we assessed her, and we recognized that this lady really was appropriate for hospice. But the team, and this is the creativity of PACE, we came together and we decided, you know what? We can give her a good death. She had a son. She had limited resources. She had really complicated medical history, despite the fact that she was only 62. She also had a history of being bipolar. She was on 21 medications. She had some issues with substance abuse, with opioid abuse. And so, but we decided, you know what? we can give this lady a good death. And so we talked to her from day one about comfort care. We have comfort care as opposed to hospice because we've got all of the resources and we could do that. And we said, you know what, we can't treat your cancer, but we can treat you and we can give you everything you need to make you comfortable. And she agreed to come into the program. So this was an example of each of the disciplines. Social work had a role in that. The nutritionist had a role in that. The spiritual care person had a role in that. Behavioral health had a role in that. Transportation had a role in that. She didn't have a refrigerator, and Thanksgiving was rolling around. We got her a refrigerator. She needed an oven so she could cook a turkey. We got her an oven. So we were able to provide all of these resources so that this woman could stay in the community. She was able to resolve some of her issues around death and dying. She was able to talk about what some of the challenges were as it related to decisions she had made. She was able to forgive and be forgiven. We got her medications from 21 down to 10, and in 3 months she died. But we felt that because of the creativity that we had with the financing part of it and the fact that you had an interdisciplinary team, there was no member of the team that was not involved in her care. Transportation knew her, so when they would go out, they would come and say, Dr. Grady, this is a bad day, we can tell. The spiritual services person would spend time with her and just minister to her and give her an opportunity to address some of the issues. So this shows how you can take an integrated model of care with a very complicated patient and then make some decisions that improved her quality of life. But I can tell you, had she not come into our program, she would have ended up in the hospital, in the unit, intubated. I know what would have happened. And so, yeah, we save healthcare some dollars, but who cares about that? We gave her a good quality of life, and we gave her a good quality death. So I wanted to share that as an example of how well PACE can pull all of these pieces together to make a difference in individuals' lives.
Yeah, Will.
So, Gwen, my question is for people in the audience who are thinking about PACE, or this idea is, and I'll put my health plan hat on since I've sit on both sides of the fence, is how would someone entertain this idea if they were starting with a relatively small patient panel when you're capitated for the full risk, which means if you have one really expensive hospitalization, you're compromised. Yeah.
Yeah, and so we had some of those challenges early on. We were fortunate that we were actually a part of a large health system. And if you're not, it would be difficult, but we were a part of the Henry Ford Health System, so we had some backup for cases like that. But often what doesn't happen is conversations don't occur at the beginning. And so if conversations occur, some of those high-cost hospitalizations could potentially be avoided. Perhaps some of that care could be provided in the home. With PACE, you waive a 3-day hospitalization to go to a nursing home. Perhaps the person does need more than what they can get at home, but they don't need to be in a hospital. So put them in a nursing home for a week and provide those services. So one has to look at what the opportunities are that may allow you to be creative with the financing that you have, be creative with the staff that you have. It's cheaper to have somebody go in the home and be with them 24 hours a day if that's what it takes. So you really have to look at some of those opportunities. But still, you can have a catastrophic case, and basically having a health system or having some backup for that is also important. And you can get additional insurance when you have those catastrophic cases too. And PACE does have the opportunity to do that.
That probably relates to the $7 million startup cost, right? Okay, let's go to questions from the audience. We'll start over here.
Sure.
And please give us your name and your organization as you ask the question.
Cheryl Mathias, I'm with the Coalition to Transform Advanced Care. I think the panel thus far has shown some amazing things that can be done through a lot of creativity by people who understand the financing streams of the public programs and the foundations and sometimes the insurers who have reason to realize that they can combine things and actually save money. My question is, I have become aware of a phenomenon that involves private investors who are willing in sort of triangular agreements to put money into programs where they have shown that the money, that it actually will save money. And I know that Johns Hopkins at least has one such program with Meals on Wheels and some private investors, and they call them social impact bonds or pay for success. I am just, as another way of finding money that is out there to bring forward this, I'm wondering if anybody has any experience with that.
We haven't done it, but we just met with Manat Phelps has taken an interest in this kind of solution and is sort of giving some thought because there's a lot of wealth in America that's parked and waiting for health-linked investments. And so I think those kinds of partnerships could be extremely valuable, whether they're social investments, whether we create other kinds of business structures. But it is, I think, urgent to find who's the value proposition to and how do we bring this kind of mercy, mission, high purpose back to our healthcare system in a way that's sustainable over time.
Yes.
Türkan Gardiner, I'm an applied statistician, but talking about the quality of life and quality of death that you mentioned, I was very impressed with the presentation this morning, knowing about the organization Caring Across Generations. A favorite aunt of mine passed on recently, and she was telling us about her life, that one of the best 12 years of her life raising her children was when an aunt of hers had to move in with them. At that time, of course, there was no assisted living, so you just had to stay with a relative of some sort or other. But this lady was a great storyteller. She had some mobility problems, but she stayed with them for 12 years and talked about her childhood, her coming from the Balkans and how they readjusted themselves. And the children loved being with her, listening to her stories. And she was a writer herself as a mother. She wrote about 4 children's books about their family. And the children didn't really read bedtime stories. They just loved listening to her. So this kind of an arrangement is one of the favorite leads in Fairfax County, Virginia. Let the elderly stay at home as long as possible through Meals on Wheels, through some other resources, home health aid, etc. And talking about and listening to the wonderful presentations, I wanted to share this story with you and consider the fact that sometimes it's more than money or resources. It's our time, it's our involvement, it's our caring, as we found out this morning how an in-law suite was formed, not even in the basement. It had to be at the same level as the living area. And it is very impressive how much work is done in that medium and with those objectives. And I admire that personally. Thank you.
Yeah, thank you. Very helpful comments. And there's another organization I think you might be interested in learning about. It's called Bridge Meadows, and it is also an intergenerational caring community where volunteer grandparents, if you will, are partnered with children in the foster care system. And both sides of the relationship benefit from the sense of purpose in caring for the younger kids, and then the kids feel a sense of stability. So it's another really interesting model.
Thank you.
Thank you. Amy, we have a question from the Twitterverse.
We do. Thank you, Peggy. So this question is from Melissa L. Williams. Her Twitter handle is @by_MLW, and she's with the National Patient Advocate Foundation. And she said session 3 highlighted great examples of community-integrated health and social services. Here's the challenge. How can these be more widely disseminated? And before you answer, I just want to say, you are all the hero. You're my heroes, and I'm sure you are heroes of everyone in the room. So I want to thank you because this was phenomenal.
Who wants to start?
Well, we've been intrigued to see that national associations can play a strong role. So there's a group called America's Physician Groups, which is a national association of managed care physicians, quite respected, that has decided that social and behavioral determinants of health are very important drivers of population health and important to their members. So they've been working to build methods to help their the practices learn. So through their media, they're going to have a cover story on their upcoming quarterly magazine. They have material at their conferences and doing webinars and emails and developing access pathways to connect with community groups that can partner with them with these regional delivery systems. So I think that kind of leadership is just an example. There are many groups, I think, that can do this. What's critical is to have that kind of voice. There's a voice in that organization, the CEO and certain physician members that step up and speak to this full integration because the money is in medicine and we're trying to move the cheese. Now, of course, that's somebody's cheese, so it makes it complicated. So I think having those credible, trusted voices for these kinds of still not fully recognized solutions is a very important form of advocacy. These proven models then similarly are powerful proof of concept that are urgent and should be disseminated through those kinds of channels.
I'd also like to comment to the National PACE Association. Again, I really feel have been leaders in driving how we can sustain and also expand PACE programs, because many of us are challenged by the fact that after 20 years, we're only serving 45,000 people in this country. And I know that MPA has developed their PACE 2.0, where they're actually looking at, the way, I'm going to say it my way, ladies, and you guys can correct me, best practices for PACE programs. You identify what works well, and you take what works well and you multiply it, you duplicate it. But that is, I think, the starting point is identifying programs that are doing something well. And typically for PACE, those are programs that are expanding, but also programs that can show metrics that they really do make an impact, both in terms of quality of life, but also utilization. And of course, utilization means dollars, but I always think we start with quality of life. So I think you look at programs that work, whatever that program is. You identify what are the components of that program that make it work. You look for what are the components that cause that program to be best practice, and then you take that and you duplicate it. But that means you have to disseminate that information. And again, I know there are two MPA ladies here that are very much working with that PACE 2.0, and so that's my little 2 cents, and I don't know if they have 2 more cents they want to add. You have 2 cents you want to add? Because I think the question is a valid one, so I really wanted to expound on it as much as we can.
You do see these kinds of models that are powerful influences in your communities and beyond, and we see this. You probably have it in your community. Who are the champions? Mm-hmm. We see the Providence Health System in Southern California has taken on care transitions, and we see Blue Shield of California taking these kinds of things on. We see our Medicaid waivers redesigning and addressing these populations. So I think finding our friends, singing in harmony, being more than one voice is a very important time to seize the opening that the Medicare Part B billing code changes represent, that the Medicare Advantage, the special needs plans, and the waiver changes all represent a portfolio of opportunities that can be deployed in small or large model efforts to move this to what should ultimately be a standard of care.
Absolutely. It should be what people look for when they're looking for best practice care. This should be it. So, yeah.
NCQA now has it in LTSS accreditation that also sets out. So I think these kinds of measures are critical.
Yes, I agree.
I'll just
Anita?
add a couple additional points to what Dr. Grady said, and thank you so much for telling people more about the PACE program. We have been working on this initiative, PACE 2.0, which was launched last year to try and grow and disseminate the PACE model. Really, we're looking to grow it on 3 fronts. One is with the current PACE organizations, with the current population, and that's what Dr. Gotti was alluding to in terms of looking at the best practices for growth, looking at PACE organizations such as her and seeing what they're doing to grow quickly, and trying to disseminate those strategies to other PACE organizations that currently exist. But then the second part of that is also to look to identify folks who would be interested in starting new PACE programs, trying to find those people, and also we'll have to figure out how to help them finance those establishing new PACE organizations in areas where we currently don't have PACE organizations. And then thirdly, also looking to expand the types of folks that we could serve. And Dr. Grady also mentioned that in her early presentation, that right now, based on the policy, we are restricted to serving those who are 55 and older and who meet nursing home level of care, where we could definitely, the type of interdisciplinary team that the PACE model provides could service those other folks who have high needs or high healthcare needs. And so we really are looking for movement from the administration in terms of updating the policies, in terms of allowing us to serve a larger community, and also allowing us to pilot with different types of populations.
Thank you for sharing that strategy.
Could I answer really
yes.
briefly also? Okay. So we were funded by a CMS Innovation Grant. Written into the Affordable Care Act was that models that were tested that way could be spread if they improved health and decreased cost of care. And so we were asked by CMS to write a PTAC proposal, which is a proposal to HHS essentially to possibly make it a Medicare benefit. So that would be the biggest way of scaling it. Within that, it's more of a passive, just people hearing about it and adopting it.
Great. We have time for one more question on Twitter and one more question in the room. I know you've been waiting patiently to ask your question, so please step up.
Hi, I'm Melissa Williams, National Patient Advocate Foundation. The question that was asked was actually mine from Twitter, but so if I may, I just wanted to expand because one theme that I am noticing is
That's 2 bites at the apple. I'm not sure we allow that.
Is noticing that the folks that we have up here on the panel are, we have Cambia Health Solutions, PACE, Care Oregon, and the theme that I'm seeing is that there's this partnership. I mean, you guys are also payers as well as health systems. And so I'm wondering if that is also maybe a solution to, advancing how we integrate health and social services.
Yeah. I would say that collaboration among different organizations that previously would see themselves as competitors is absolutely part of the picture. We're moving to a new world, and I think we need to promote new models and not to promote them as adversaries, but finding the win-win in the arrangement for both organizations, for sure. Thank you. Amy, there was another question that came in.
Actually, my comment.
Oh, very good.
So Amy Berman, John A. Hartford Foundation, sorry. But I just wanted to go back to the PACE 2.0 work and just point out that this work is being supported by the John A. Hartford Foundation in partnership with West Health and also the Commonwealth Fund. And the goal is to significantly expand PACE to move to 200,000. So, this work is really going to be built on exceptional places such as yours. And so thank you so much. Thank you.
And Amy, thank you for your support and the Hartford Foundation's support. Okay, that concludes our session. I want to thank the phenomenal panel, not only for the session, but for their work.
Thank you.
again, thank the panel for illuminating our way and sharing the highlights, and our moderator, Peggy. And we have promised a provocative meeting, so I would encourage everybody to come back right at 3:30 and hear from my co-chair and former administrators of both HCFA, CMS, and aging to hear what some of the solutions can be. Thank you.